So let's just look at neuroblastoma. Just revision sake. We may not touch all the details. So it's one of the most common extracranial tumors in the childhood. So where does it arise from? Primitive neural crest cells. And if you see, majority of the cases, they occur in the less than 10 years age group. And it's one of the most common small cell, small round blue cell tumor. And it is linked to certain germline mutations like the ALK and the FOX2B gene. And most common primary site for neuroblastoma is adrenal medulla. 40% of the cases occur from there, and then other paraspinal sympathetic chain. So it basically arises from the neural crest cell. And the neuroblastoma spreads via the lymph nodes in majority of the cases. See the prognostic factors that includes age, then certain gene mutations like gene amplifications like MYC gene, the staging, and certain chromosomal deletions. So age, if it is more than 18 months, it's bad. Okay, similarly, to see the INRG. INRG is the staging, which is L1, L2, M and MS. L1 is localized without image defined risk factors. Prognosis is good. That is localized tumor not involving any vital structures, and it is confined to one body compartment like that. So it is a localized disease. If there is loco-regional disease, more than one image defined risk factors, then it becomes a L2, intermediate prognosis. 5 years is close, 5 years is close to more than 75%. Then it becomes metastatic, poor prognosis. The prognosis drops down to less than 45, 40. And then we have MS, metastatic disease in children less than 18 months, confined to skin, liver, bone marrow. So the issue with MS is not the issue. The unique thing is that it has excellent prognosis despite metastasis. Stage M, distant metastasis, has poor prognosis, but MS, metastatic disease in children less than 18 months, confined to skin, liver, bone marrow, less than 10% in marrow involvement, is excellent prognosis despite metastasis. Now that is something we need. And then amic amplification is one of the most independent adverse factor in neuroblastoma. It is usually associated with a poor response to systemic therapy, inferior survival and advanced stages. So MYC amplified tumor usually falls under a high risk disease. And if it's poorly differentiated, unfavorable. If it's differentiating neuroblastoma or a ganglioneuroblastoma, then it is one of the favorable subtypes. And we have certain molecular markers. Again, in molecular markers, we'll see 11q deletion, ALK mutation, MYCN amplification, MYCN amplification. All this is unfavorable again. Only hyperdiploidy and TRKA expression is considered favorable. Otherwise, this MYC, 11q deletion, 17q gain, ALK mutation, all of that is considered as unfavorable. So this will be the risk stratification. So based on the risk stratification is how the treatment is basically decided. One another named classification is the modified Shimada classification. That again divides it into favorable, unfavorable, and then age, based on age it divides. So if you see the imaging, technically, since it's a small round blue cell tumor, neuroblastoma, we need to consider neuroendocrine kind of tumor. We need to consider MIBG, technetium 99 labeled MIBG scan. 90% of neuroblastomas do light up with MIBG. If MIBG non-avid, only then we go for a FDG PET scan. So management again depends on low risk, intermediate risk and high risk. Low risk is usually surgery plus observation. Surgery is the only preferred treatment option because it's a low risk, localized disease, gross total excision wherever feasible, and then patient is under observation alone. Chemotherapy is used only if there is disease progression after that, or incomplete resection with progression, or symptomatic. The common chemotherapy, if used even in the low risk, it is the carboplatin etoposide based regimen, 2 to 4 cycles maximum, because it's low risk. Carboplatin etoposide. There's a three drug combination which usually they use for intermediate risk group. One another combination, 3 drugs, cyclophosphamide, doxorubicin, etoposide. Most commonly used is carboplatin etoposide, platinum with the etoposide in neuro. Then we have intermediate risk neuroblastoma, where they usually start with initial chemotherapy, delayed surgery, and then further adjuvant chemotherapy. So if you see the COG regimen for intermediate risk group, it will contain carboplatin etoposide, cycle A. Then cycle B will contain cyclophosphamide, doxorubicin, etoposide. And this is alternating 4 to 8 cycles, which approximately is 12 to 24 weeks, and then depending on response, surgery is performed after tumor shrinkage. Complete resection if safe, they proceed with complete resection and then consider. See, we have a high risk disease, so a high risk, automatically systemic therapy comes into play, can be multimodal, may require radiation, but induction chemotherapy is that standard. COG protocols, there is 6 cycles of induction chemotherapy. This induction chemotherapy has this Kojak regimen, where phase 1 is induction with Kojak group. Cycle A is cyclophosphamide, topotecan. Cycle B is cisplatin etoposide. Cycle C is cyclophosphamide, doxorubicin, vincristine for a duration of about 18 weeks. This is alternated into 5, into 4, into 3. It's a very complicated regimen with multiple cycles of various drugs which are alternated. Cyclophosphamide, topotecan is one group, then which is alternated with cisplatin etoposide, and then which is alternated cyclophosphamide, doxorubicin, vincristine for a duration of 18 weeks. And then there is the consolidation chemo, which uses again busulfan, melphalan, and then patient goes for surgery. Carboplatin etoposide, melphalan is used for consolidation after surgery, and then which is followed by autologous stem cell rescue. In the CO protocol, it's busulfan, melphalan for consolidation given after surgery. So the basic thing is that we have induction chemo followed by consolidation chemo. In between we put the surgery, and then so induction chemo, surgery, consolidation chemo, and then maintenance after transplant, for which they usually use isotretinoin. So RT, all patients after surgery, high risk disease, residual disease, persistent metastatic foci, selected cases, consider RT. Age less than 18 months with mets in the liver, skin, bone marrow, MYCN amplification, residual disease, unresectable disease, symptomatic methane emergencies, RT is considered in neuroblastoma. The current COG standard for a primary tumor bed, if you are giving in a high risk disease after resection, it is 21.6 gray. In 21.6 gray for a microscope, 21.6 gray in 12 fractions, 1.8 gray per fraction is the COG protocol. If there is gross disease, we give 30.6 to 36 gray. If there is gross disease, 30 to 36 gray is given. And if there is a persistent metastatic foci, depending on the site, they give anywhere between 21.6 to 36 based on the site, size of the lesion, all that. There are other protocols where they give 10 gray to the primary and then 10 gray to the TBA, total body, which is also reduce recurrence and improve local control rates in certain cases. And in major advance in the high risk neuroblastoma is sometimes this latest maintenance immunotherapy, where they give anti-GD2 immunotherapy. GD2 antigen on the neuroblastoma cells is targeted with the drug dinutuximab. So instead of isotretinoin alone, which was the classical one, now in certain very high risk cases they are doing dinutuximab dinutuximab plus isotretinoin, which has improved in one of the COG trials. It has improved the overall survival and event-free survival compared to isotretinoin alone. Isotretinoin alone, the dose is 160 mg per meter square per day, day 1 to 14, every 28 days, 6 cycles. It usually promotes differentiation of residual neuroblastoma cells. So stage MS neuroblastoma, previously we had discussed, the usual treatment is observation unless and until patient is symptomatic, organ dysfunction, respiratory compromise, massive hepatomegaly, only then treatment is given. Low dose chemotherapy with carboplatin etoposide or cyclophosphamide chemotherapy, and the outcomes are excellent. So if you see the low risk and the stage MS have overall survival, 5-year overall survival more than 90-95%. If it's intermediate risk, still the 5-year overall is more than 85%. High risk group, it is dropping down to 50%, as well, 50 to 70%. Now this is the prognosis wise. So initially we thought what exactly is neuroblastoma, some basic points on the risk factors, age, molecular markers, site, stage, then staging, then the named classification is called modified Shimada. Then we have management based on the poor risk group factors. Imaging, in between we saw regarding investigation imaging, low risk, intermediate, high risk. Systemic therapy is always the backbone, has always been there. In high risk cases it acts as a myeloablative therapy, induction, surgery, then consolidation, then RT, everything is there in high risk case. And timing of RT, usually after surgery and high dose chemotherapy, it is usually planned. The dose for RT is usually 21.6 gray, and then for microscopic disease, for grass disease we give 30 to 36 gray. And then maintenance immunotherapy, all that we have seen.